Good evening and welcome, everyone. I'm Ann Belegia, and I'm a member of the Osher Lifelong Learning Institute at Southern Oregon University, also known as OLLI. Pleased to welcome you to tonight's program featuring Dr. Nathan Funk talking on unlocking the secrets of the heart, when, how, and why. And I'm grateful for Dr. Stephen Hirsch for serving as the moderator for not just this series, but also the previous three. I have the honor of introducing Dr. Hirsch, who has been a longtime Rogue Valley physician in internal medicine and hospitalist, and most recently served as the director of medical affairs for Asante Ashland Community Hospital and Asante's medical director of quality and patient safety. Dr. Hirsch is going to be introducing tonight's speaker and providing some background on him. And please welcome Dr. Hirsch.
My pleasure tonight to introduce Dr. Nathan Funk. Dr. Nathan Funk is originally from a small town in Iowa where his father was a veterinarian. Dr. Funk initially considered veterinary medicine, but it was our advantage that he changed directions and went to medical school at the University of Iowa. He then went to OHSU in Portland for internal medicine training and then moved to Alaska, where he worked for a year as an internist with the Alaska Native Medical Center. He returned to Iowa for his cardiology fellowship, where he developed an interest in cardiac imaging and valvular heart disease. Dr. Funk moved to Medford with his family about 10 years ago, and I'm very lucky to have him as part of the cardiology team. Dr. Funk and his family enjoy the outdoors. They enjoy hiking, camping, and trail running. And at this time, it's my pleasure to bring you Dr. Funk.
Thanks a lot, Steve. I really appreciate it. And we all are, for those of you who don't know, Steve has been a long time presence in our medical community. And so we're really going to, he's leaving the area and we're all going to miss you tremendously. Just thank you for all your contributions over the years. It's really immeasurable the amount of time and dedication you've made to making people healthier, live longer, feel better, and it takes a lot of long nights and long days and a lot of dedication. So thank you for all that you've done over the years.
Thank you.
So I am presenting on the secrets of the heart, and so how do we figure out what is wrong with the heart, and how do we use that information in our diagnosis and treatment strategies? And so I've organized things along the way here by diagnoses, and so just going to talk about a couple different areas that we commonly deal with. As Steve said, I spent my cardiology training at the University of Iowa and took a particular interest in imaging and in particular cardiac CT and echo. And so you'll see lots of pictures of that here. On the left, this is a coronary CT angiogram. It looks like a bunch of spaghetti noodles here, but this is actually the blood flow to someone's heart. And this was taken on a CT scanner. I'll show you a little bit more about how we use that in diagnosis. This is a mitral valve, which we're going to talk about. And you can see that there's something kind of coming out at you right there. And so this is a 3D transesophageal echocardiogram. And so you get to see the leaflets moving, and it's like you're sitting in the left atrium looking down on the heart, just in the same way that a surgeon would if he opened up the left atrium. And so it's really, of all the things that I do while I'm doing it, most often while I'm doing 3D TE, people say, wow, that's pretty cool. And so, and then this is an image created by DALL-E or AI. And so maybe we'll talk a little bit at the end about how AI might play a role in cardiology care in the future. And so here I typed in unlocking the secrets of the heart in a Southern Oregon forest. and this is the image that Dolly generated. So let's start off and talk a little bit about echo, and I'm going to first start off with a case of aortic stenosis, but before I get to that, I just want to talk a little bit about how one of our mainstays of imaging and diagnosis is the echocardiogram. And so sonograms is the same thing that you would use to image a pregnant woman and her fetus, and we do it on the heart, and so it gives us these live moving pictures. And so here you can see a sonographer. Of course, all of our sonographers are dressed in suit and ties every day. Not really, but this is all I could find on the internet. And so here you have a patient who's getting their echo done, and we put a little gel on the chest just to make the contact and pictures better. And remember, ultrasound is sending sound waves to the heart, and so basically you're penetrating the chest with sound waves, and as you change tissue planes, that bounces back to the transducer, and when it knows when it sent that sound wave, and then when it returns, that tells it to put a little white dot right there. And so when you put all of those things together, that's how you get this moving picture, and you're getting 52 frames every second and at a depth of 16 centimeters. And so here, for those that aren't as familiar with how blood flows through the heart, blood flow comes back to the right upper chamber, right lower chamber to the lungs where it picks up oxygen, then the left upper chamber, main pumping chamber, and out through the aorta. And you have all these one-way valves that keep blood moving in the right direction. And so here's the aortic valve, which we're going to talk about. And so in this picture here, the probe is aligned along this way. And so you get this 2D slice of the heart that shows us the left lower chamber here, the left upper chamber, the aortic valve, the aorta, and then just a little slice of the right ventricle that overlies the left ventricle in that plane. And so when we think about the heart in this plane, here you have the aorta, which lies in the center of the heart. And then, so this is looking from the top down, kind of the surgeon's view of the heart. You have the tricuspid valve on the right side, the mitral valve on the left side, and then the pulmonary valve lying in front of the aortic valve. And here, these little nubbins here is the coronary artery, ostia. And so the coronaries come off there and run on the surface of the heart, burrow down and feed the heart muscle oxygenated blood. And so the aortic valve usually is like billowing sheets. And so it just opens widely as the heart pumps, and it flips open and blood pumps into the aorta. And then its job is to cinch shut, because as the lower chamber is relaxing, blood is to come in through the mitral valve. And this blood we want to keep going out to the rest of the body to supply oxygenated blood. And so its job is to keep blood from leaking back from the aorta down into the main pumping chamber. Now on this view, so this is an ultrasound of the heart in this cross-sectional view in the short axis here. And so this is the aortic valve, and there's something wrong here that you might notice. It's more bright than it was on that other view of a normal aortic valve, and it doesn't open like it should. So here it's the right leaflet, the left, and this is what we call the non-cusp. And so the right coronary comes off here and the left. And then as you can see, there's just a little bit of space in there as blood is pumping out. And this is what we call aortic stenosis. And so the main problem with this is that it's putting more strain on the heart muscle, so that as it squeezes, it's having a hard time pumping out the blood as it normally would, because these leaflets are restricting the blood flow. They're making it harder for the heart to do the same job that it would if the leaflets were opening widely. So aortic stenosis is a diagnosis mostly of older people. Around 5% of the population older than the age 65 are diagnosed with aortic stenosis. Younger patients can be diagnosed if they have what we call a bicuspid valve. So some people congenitally, or they're born with it, where they have fusion of two of the leaflets, either these two, the right and the left, or the right and the non. And those patients develop aortic stenosis much earlier, like in their late 50s, early 60s. And so if aortic stenosis is causing symptoms, then without treatment, about half of those patients are going to be dead in about 2 years. And so it really is a diagnosis where we need to do something if the valve is restricted. That diagnosis is similar to what many cancer diagnoses are left untreated, where they have a mortality rate of about half in 2 years. And so we'll talk about kind of the workup and how we decide whether someone needs surgery or not. Another tool that the ultrasound gives us is a quantitative measure of how tight the valve is. One of the things that the ultrasound probe is able to do is bounce sound waves off of the red blood cells. So just like the officer who's on the side of the highway is using his radar gun to tell how fast your car is going, what we're doing here is bouncing sound waves off of the red blood cells going through the valve, and that signal comes back to the probe and it tells us how fast the blood is moving along this line. And so the peak velocity is assumed to be at the narrowest point. So just like if you were to step on a garden hose or put your thumb over the end as the water's flowing, when you do that, the water goes faster. And as that speeds up, we can detect that on ultrasound, and that gives us a quantitative measure of how tight the valve is. And so the narrower the hole, the faster the speed of blood going through there. And so over time, we've developed kind of an algorithm of who really needs help, and those patients who have a peak velocity greater than 4 or a mean pressure gradient. So from this velocity, we can calculate and say, what is the pressure upstream and downstream across the valve? And I'll show you a little bit of a different way of looking at that in just a second. And so from that, we can calculate a rough approximation of the size of the hole. And we say a valve area less than 1 centimeter squared is severe. Here's a view from that same parasternal long axis view where you have left lower chamber, left upper chamber, aorta, and aortic valve here, and the right ventricle overlying here. You can see that these valve leaflets are thickened and calcified and don't open very well. And that's indicative of aortic stenosis. So one of the next tools that I want to introduce is a cardiac CT. And so you may be familiar with CTs of the brain or the abdomen, a way to kind of peer inside the body and get a two-dimensional picture. And so this is a gantry that's shining X-rays, and as it does so, it uses some complicated mathematics to back calculate where the location of that pixel is. And it gives you this two-dimensional slice, so we say, of the body. It's like you're cutting the body like a loaf of bread. And so we can actually do this with the heart. And so you might say that's a little bit of a challenge because the heart's moving. Our gantry moves each half cycle around is 90 milliseconds. And so that's extremely fast. And what that allows us to do is to get 10 pictures of the heart every second. And so in that 100 milliseconds, we find some periods where the heart is essentially at a standstill. And in those images, we get these nice, clear pictures. And so one of the things that I do is I read all of these cardiac CTs of the aortic valve patients. And so here you can see, here's the right, left, and non-cusp, the left upper chamber, the right upper chamber, and then this is the pulmonary outflow tract here. This is the left coronary artery, the right coronary would come off here. And you can see that this valve is really calcified. So calcification shows up as bright material on a CT because the X-ray can't penetrate through it. And so it's this bright appearance to it. And you can see that all of that calcification is limiting the ability of the valve to open like it should. The other thing about cardiac CT is we get a look at things in 3 dimensions. And so these two planes are orthogonal to each other. And so this is one dimension. This orange plane is along this dimension here, and then the blue plane is down here. And so by swinging these planes around, I can, in a sense, look around in the heart in all three dimensions. And that's really useful for lots of different things. One of them is to get into the plane of the valve here, because when we think about replacing the valve, we need to use the CT scan to help us do that, which I'll talk about here in just a second. But before I do that, one of the other things that we do for our aortic stenosis patients when we're thinking about doing valve replacement is we also want to know, do they have coronary disease? So before we replace the valve, if we're going to do an open heart surgery, we want to know if they have blockages in their coronaries so that we fix those at the same time. If they're opening up the chest, they may as well bypass the coronary arteries if needed. And so here you have a coronary angiogram, and so this is how we do it here. So the patient's lying on the table. You've got an X-ray source underneath, and it's shining X-rays through the patient. And we've got a catheter going in through the artery in the leg and feeding this tube up to the heart right here. And so we're injecting contrast. That's a solution that shows up on X-ray, and it fills the coronary arteries. And so we can see if there's any blockage there. So if there were a blockage, it would be a little pinch in the artery. And so here we're looking kind of at the heart from the top down. And so this is the artery down the front side of the heart, and these are the branches that are going out onto the lateral wall. And then you see the one back behind here. This is feeding the lateral wall of the heart. And so also, while we're in the cath lab, I can put a catheter across the aortic valve and measure the pressures in real time. And so this purple line is the left ventricular pressure, and this red line is the aortic pressure. And so as the heart squeezes, you see the left ventricular pressure go up, and it's not as high as the aortic pressure. And that's because of the restriction. The leaflets aren't opening, and so the pressure is higher upstream than it is downstream. And then we can measure this gradient. And so this patient's gradient is 37. So it's getting there. It's pretty high, but not quite severe. And you can also see what their filling pressure is. So the amount of pressure in the heart when the heart's relaxed tells us how full the heart is with blood. And as this pressure gets higher and higher and higher, that backs up into the lungs. And that's one of the main causes of why the heart can cause shortness of breath, is because pressure is backing up in the system. And when it backs up into the lungs, the fluid kind of oozes out, and then you have all this water in your lungs. And that can make you short of breath or have a cough or not be able to do the kinds of things that you want to do. Obviously, there's lots of other causes for shortness of breath, but this is one of the main ones that we're thinking about in someone short of breath. And it also relates to aortic stenosis. So the main symptoms that someone has, by far and away, shortness of breath is the major one. Also, other symptoms like chest pain or feeling lightheaded or like you're going to pass out are other symptoms that we ask our patients about with aortic stenosis to determine whether they're having symptoms from their valve disease. So when we think about valve replacement, we can do this one of two ways. One is to open up the chest. This is kind of the old-fashioned way. And so the breastbone is split and the heart is opened up and the old valve is cut out and a new valve is sewn in place. And so here you have all different types of valve. This is the Starr-Edwards valve that was first developed at OHSU by Dr. Albert Starr. And if you go up to the library at OHSU, they have a whole exhibit based on Dr. Starr and the medical devices and equipment that he developed while he was there. And here you have two mechanical valves. And so these are different forms of polycarbonate leaflets. And so here's a tilting disc leaflet where this is sewn into the annulus and the old valve is cut out. This is sewn into that area. And now these leaflets open and close. To have one of these valves, you need to be on Coumadin or warfarin over the long term, and that inhibits some clotting factors in your blood, which allow it to be very slippery and not to clot on the leaflets. and not have a stroke or have some other valve dysfunction. These leaflets are what we call bioprosthetic leaflets. So these are made out of tissue. So this is cow pericardium, or the lining, the sac that surrounds the cow heart is called the pericardium. And they basically take that tissue, which is relatively inert, meaning that your human body doesn't react against it. And it also has some chemical fixatives to it. And so they fashion it into this 3-leaflet valve, and then it opens and closes, and it takes over for the function of your valve, and it keeps blood from leaking from the aorta back down into the main pumping chamber. Has these sewing skirt on it, and it's sewn in place there. This is a pig valve, and so this is called a xenograph valve. And so basically, they take the pig valve in whole out, and they sew it or fashion it or attach it to this stent here, and that now takes over for your old valve. But in the last years, we have developed a new technique, and this is called transcatheter aortic valve replacement. And so in this strategy, we have developed a model which doesn't require opening up the chest. This can go in through the leg. And so here we have a valve that's collapsed down on a balloon. So it's one of these 3 sizes of valve, and you can see there's a cage here, and then these prosthetic leaflets are sewn into that. And this cage can collapse down just like this on top of a balloon. And so this goes in through a sheath through the leg, and it's fed up through the aorta backwards, up through the aorta, around the aortic arch, and then down into the old valve. So here you can see this is a calcified restricted valve, and this new valve collapsed over a balloon is pushed down into the old one. And then we pace the heart. And so you can see here that we're pacing the heart rapidly. And so it essentially stops the blood flow from ejecting out of the heart. And that allows us to expand the valve. And so the balloon is blown up, the cage is expanded. And then once it's all expanded, then we can let the balloon down. You see right there where it balloons down. And now we stop pacing, and now the heart starts ejecting blood. So here you can see again, it's pacing very fast, and there's not much blood flow. Valve expands, and the balloon goes down. And so then we just take everything out, and we take the sheath out of the leg, and the patients generally leave the hospital either the next day or the day after that. With surgery, oftentimes patients will be in the hospital for a week or more. And now we've been able to get to the point where patients stay in the hospital less, and it's a safer way to do it. It's like a better mousetrap, and it allows us to treat much sicker patients than we had in the past. So with that, I'll pause. I don't know if anyone has any questions that we have come up with so far.
Yeah, Nathan. First of all, I think you mentioned a little bit, but since we're talking about aortic stenosis, can you talk about the symptoms of aortic stenosis, the severity, and how we determine severity? And also, you're talking about calcification. And maybe you can talk a little bit about calcification. Is it always bad? Is it ever good? How do we prevent calcification from developing?
So with your first question about the symptoms, so as I was saying, shortness of breath, chest pain, and lightheadedness, those are the symptoms that we think about when someone has severe aortic stenosis. Obviously, each of those symptoms have lots and lots of other causes that can cause that, but aortic stenosis is one of them. It's on the list. And so that kind of guides us when someone we know they have severe aortic stenosis by their echo, and they have one of those symptoms. Then we think, well, that's certainly a plausible reason, and we think it may be time for them to undergo treatment. One of the things that in the pathophysiology of how aortic valve disease progresses is with calcification. And so Calcification in the body is a response to some kind of hemodynamic stress, whether that be in the coronary arteries or along the aortic valve. There is some signal that the body is receiving that says we should harden this tissue. We should try to buffer it up, or we should spackle this weakening with calcium. And so there's this uh, there's this cascade of processes which occurs, which I'll touch on in a little bit when we talk about calcium screening. The end pathway of that is for it to calcify, which it's trying to counterbalance the stress, but on the other hand, it's also causing restriction of the valve. And so that turns out that that's something that we can fix. And and then the last question, remind me again.
So how can we prevent calcification?
Yeah.
Can we prevent it from
So a lot of
worsening?
people ask me, should I drink less milk or should I not take this calcium supplement? That has no relevance in terms of how much calcium you lay down in your arteries or in your aortic valve. And aortic stenosis, we have not come up with a mechanism to prevent this with either diet, or exercise, or medications. This is probably some uh, role to play with genetics, and there probably is some environmental role to play as well with other factors. Um, but we have not been able to find a good preventive way to avoid aortic stenosis at this point.
One last question about this. It's not infrequent that I or someone else will listen to somebody's chest, somebody who has no symptoms whatsoever, and hear a sound that makes us think that aortic stenosis is present. We might get an echocardiogram that confirms that, but says that it's mild. What do you do with somebody with asymptomatic mild aortic stenosis? And specifically, how often do they need to be rechecked?
So that's right, Steve. So when you're listening to the heart and you have blood flowing through a narrowed hole, just like if you were stepping on a garden hose, it might make a sound that you can hear with that. That's the same thing that we hear with our stethoscope, is that sound of the turbulent blood flow as it's going through this narrowed hole, and that tips us off that there may be narrowing there. So we do an echocardiogram and we find that they have mild aortic stenosis. If a patient has mild aortic stenosis and they have no symptoms, there's really nothing that needs to be done at that time. There's nothing medication-wise or other behaviors that you can do to keep it from progressing. So really, we just watch it over time. If somebody has mild aortic stenosis, I typically recommend that they get an echocardiogram in 2 to 3 years or so to follow up on it. Once someone has moderate aortic stenosis, then we start to follow it every year. If someone has severe aortic stenosis, but they have no symptoms, there are times where we can wait if it's just crossed into the severe range, but they have absolutely no symptoms whatsoever. We have time in that scenario where we don't need to jump in and replace the valve, but could do an echocardiogram either every 6 months or a year. So I'll move on here and talk about coronary artery disease. And so many of you are familiar with blockages in your coronary arteries. And so this is a process that's not dissimilar to what I just mentioned with aortic stenosis. And so as the vessels feel stress on them, they start to lay down cholesterol plaque in the walls of the arteries, and this can cause a restriction of blood flow. So as the heart's working harder and faster, it needs to increase blood flow to the heart muscle. But if it can't, because there's a blockage there, then that can create a mismatch. So the heart's working harder than the blood supply that can get to it, and that mismatch can cause chest pain. And so that's what we call angina. Angina is a very specific term that we use for chest pain that's related to blockages in the coronaries. Having blockages like this can put you at risk that the plaque could rupture. When it does, it exposes the gunk underneath to the bloodstream, and the body thinks it's bleeding. And so it forms a clot on the surface of the plaque, which partially or fully obstructs blood from going downstream. And that's what we call a heart attack. And so having plaque like this puts you at risk for this, and that can be bad because you can die from a heart attack. And so all of the kind of screening and imaging studies that we do trying to detect atherosclerosis are targeted at trying to decrease the risk that people have a heart attack. When someone has symptoms of chest pain, So not infrequently, we get referrals for patients with chest pain. And so it's very hard to determine whether someone has a blockage that's causing that chest pain, because there are lots of other causes for chest pain. If you take everyone that presents to their primary care provider with chest pain, only a few percentage of those are actually have their chest pain related to a blockage in a coronary. In terms of patients that come into the ER, it's about 20%. So in the primary care position, it's around 3 to 5% of patients with chest pain that it's related to a blockage. And in the ER, it's about 1 in 5 patients that come in. So, you know, there's the vast majority of patients who have chest pain, it's not related to their heart. But how we try and sort that out is why we do stress testing. And so a stress test is a non-invasive way of imaging the heart, trying to see if there is a blockage there. And the concept is that if you had a blockage, say 90%, believe it or not, at rest, the flow to the heart muscle downstream is still normal. And so we inject you with a chemical that's taken up by the heart muscle, and it emits a signal to the heart or to the camera. And that signal makes the heart light up when we take images of it. And so if the blood flow is normal, or even in the setting of a blockage, that flow is still normal. Hold on just a second. Let me just. Sorry, I'm on call here. So even though there's a blockage here, the heart all lights up normally, and then we put the patient at stress. That could either be with walking on a treadmill, or it could be with a chemical stress. And so the chemical stress increases flow normally to the normal blood vessels, but it can't increase the flow to the one with the blockage. And so it looks like a relative defect, like a bite out of the donut. And so here you can see a normal scan. This is someone who had no blockages, and you can see at stress and rest, all of the heart lit up like a Christmas tree. And so it's bright. Here's the patient lying on the table. They've got the camera going around, and the signal inside the heart, or the chemical inside the heart, is emitting a signal to the camera, and that is what makes our image. Now here you may notice that there's a difference. And so here you have the same donut, but there's a bite out of both the stress and the rest images. And so that's abnormal. And so on the basis of this, we would say, you know what, this patient chest pain is probably from a blockage, and we should do further study. So we took this patient for a heart cath, and this is what we found. So again, here's our catheter injecting contrast into the coronary arteries, filling it. But right here, what's that? You've got a blockage or a bite or a pinch in the artery. And so that's cholesterol plaque, and it's restricting blood flow down to the lower heart muscle. Here's the right coronary artery, and you can see this is one where there's no blockage. There's just minimal kind of lumpy bumpies along the edge of the vessel, and providing good blood flow to the underside of the heart. And so when you have a blockage like this, there are scenarios where we would put a stent in. And so a stent is a collapsible Chinese finger trap you can see here. It's this metal cage, and it can be fed over a very thin wire. And there's a balloon on the inside of the stent. And so you can feed this into a plaque and then blow up the balloon, and it pushes the plaque to the outside. And you decrease the balloon and pull everything out, and the stent stays behind, and you reestablish flow downstream to the heart muscle. And so here's the same patient after stenting, and you can see that no longer is there a pinch there, and they've got good flow to their heart muscle. So I don't know if there's any questions with that. We're starting to get a little shorter on time. I don't know if you want me just to keep going or.
We didn't have a lot of questions about this segment, so why
Yeah.
don't you go on?
So I'll talk a little bit more about this process of atherosclerotic disease. There's going to be a quiz on all of this information at the end of the talk, so you'll have to quickly memorize this. Just kidding. And so here we have the inside of the vessel. This is the vessel wall. And you have this process of calcification. And so this is one, as I was talking about, LDL sticks at areas of inflammation or stress, and then it becomes oxidized. And that oxidized LDL can get recognized by the immune system. So that your body's defense mechanism recognizes that. And it starts sending out all these chemical messengers, and it draws in more inflammation, and the immune system eats up all the LDL cholesterol that's there, and it forms these big fatty lakes, or cholesterol lipid lakes in the underneath, and that's what's growing and forming this plaque, which is pushing into the lumen of the artery. One of the other chemical messengers draws in these cells called smooth muscle cells. So these normally are the kind of cells that help your arteries squeeze. So it makes the arteries stiffer and can raise your blood pressure if it needs to. But one of the other functions, one of the amazing functions of the body, is to bring in these smooth muscle cells, and then they transform into bone producing cells, believe it or not. And so these cells start, they transform into bone producing cells and start secreting it into this plaque. And so it is hardening the artery. And so that's this whole cascade from LDL to calcium is hardening the arteries. And so that is what we call coronary calcification, or coronary atherosclerosis. Atherosclerosis means vessel hardening. And so one of the things that was developed is somebody had the idea, hey, we could do a CT scan. CT scans show bone really well, so let's just look for the bone like material that's in the coronary arteries, and let's just see if that correlates with who has heart attacks and doesn't. And so we take this low radiation dose CT, and we go in and trace it with the software, and it counts up all the pixels that are above a certain threshold that are white, and it adds those all up. And when you do that, that gives you a score. And so here you have various groups of patients who had 0 calcium, a little bit, a medium amount, and a lot, and then followed them over time and found a very stark difference in terms of who had heart attacks and who didn't. So those who had more calcium had more heart attacks over time. So there's a bit of a paradox here, because what a heart attack is, when you're looking at the pathophysiology, is actually happening at the soft plaque, not the hard plaque. It's the plaque that has this lipid lake, and it's eroding this fibrous cap, and then suddenly that bursts and it causes the blood to coagulate or to form a clot there. And that's what blocks off the vessel and causes an event, a cardiac event. It's usually not the area in the vessel that's already 100% hardened. But where we know that there's hardened plaque, we also know that there's soft plaque. And that's why you see this big correlation between who has more calcium and who has more heart attacks. And so in patients, does everyone need a coronary calcium score? No. We can tell from your heart rate, from your blood pressure, cholesterol, age, whether you're diabetic, whether you're a smoker, and your family history. Those factors can sort patients into groups of low, medium, and high risk patients. And so patients who are already at high risk, we already know what we should do for them. There's lots of things. We should control their blood pressure, their cholesterol, they should exercise, eat right. We should do that for patients who have high risk. For those at low risk, we know that they in general aren't at risk for heart attack, or are at low risk, and so they probably wouldn't benefit from controlling their cholesterol tightly. It's those group in the middle where, and especially those that are somewhat reluctant to take cholesterol lowering medications where a calcium score can really help either kind of bring it to life where the patient really needs to be on a cholesterol medicine, or reassure them and say, you know what, based on your lipids and blood pressure, we thought that you had a high risk for or were at risk for having a heart attack, but actually we did a calcium score and it's so low that you're really not at much risk for a heart attack, and therefore we can omit the cholesterol lowering medication. So another way that we can use CT to diagnose chest pain outside of a stress test is to do a coronary CT angiogram. So this is similar to what I was talking about with the aortic valve, but here we're looking at a three-dimensional view of the heart arteries. And so here we could actually see the plaque in the artery. Remember, a stress test, a functional stress test, like a nuclear study that I demonstrated earlier, that's looking at blood flow. Here, we're looking at an anatomical test. So this is one where we're actually seeing the cholesterol plaque in the walls of the arteries, and we're measuring on a direct basis whether there's a stenosis or a blockage there or not. And so this is we're trying to get to a similar answer of whether someone's chest pain is related to their heart, but it's just a different way of going about it. I'll pause there if there's someone submitted any questions, or I can keep
Yeah,
going.
there's a number of questions.
Okay.
And it has coronary calcium and just calcification in general tends to be fairly confusing. So you mentioned one question, which is it worth doing a calcium CT scan to get a calcium score? And you talked about that depending on what the risk factors somebody has. Um, can you talk a little bit about people who have incidental findings of calcium in their coronary arteries? We do lots of CT scans, and those can CT scans of the lungs or the belly, and those can identify calcium in the coronary arteries. Is that the same? Is that different? And should we be responding to those?
That's a great question, Steve. And so, yes, we incidentally detect calcification in the coronary arteries on many, many CTs every day. So, in general, if you're older than the age of 65, the likelihood that you have zero calcium in your coronary arteries is very low. So, almost everyone, by the time that they reach their upper years, are going to have some element of calcium in their coronary arteries. And so that does not mean that the artery, that we know whether the artery has a blockage or is restricting blood flow to it. The calcium can just form on the surface of the vessel on the outside without growing into the vessel itself. And therefore, the patient may have no symptoms at all, no shortness of breath, no chest pain, and be very active. And so there's really, at that point, when we look at how much cholesterol is there, we're really asking, what can we do to prevent a heart attack over the long term? In the sense that we don't need to take someone to the cath lab and put a stent in, but what can we do with medicines and diet and exercise to decrease their chance of having a heart attack over the long term? So if we have someone that incidentally we find calcium on a scan, say, of their lungs or some other CT that they're having, then typically we just think about that. What are this patient's risk factors, and how could we treat them more effectively, either with cholesterol-lowering medication, with diet, exercise, or blood pressure control, quitting smoking.
But I want to emphasize what you're not saying there, Nathan, is you're not saying that we're looking at therapy directed at reducing the amount of calcium. So the calcium is not the culprit. The calcium is just a marker that there's a problem there.
That's correct.
Yeah. So that's the nature of a lot of questions here. And let me just throw out an answer to a question I'm seeing, that this test that Nathan is describing, the calcium CT score, is available in Southern Oregon, but it needs a provider's order, and those will be based on whether it's necessary or not, based on other risk factors. And there are still issues around insurance payment for those tests.
Yeah, amazingly, a calcium score is quite inexpensive. So right now, it's somewhere around $300 is what out of pocket is what the hospital charges for a calcium score, which, you know, in today's day and age with all of the medical tests and so forth, it can at times provide a lot of value. And so even without insurance cover, oftentimes it's doable, and it really does help us over the long term to make treatment decisions.
Nathan, how do you think about the CT angiogram? Does it replace a standard angiogram? Does it replace doing a stress test? How does that algorithm work?
It's a great question. So one of the downfalls of a CT coronary angiogram is how much calcium is in the vessels. And so as you can see here, that calcium, we call it calcium blooming. So remember, as the CT scanner is whirling around the patient and shining X-ray radiation through the patient, when that calcium blocks that X-ray, that process makes the calcium grow or bloom. It's not actually growing or blooming. It's just an image manifestation of the calcium that is actually larger than life. It's larger than real life. And so one of the things about a about a CT coronary angiogram is it's very, very sensitive for coronary disease. And so it's a test where if you're looking for it, you're not going to miss coronary disease. Whereas a functional test, like a nuclear study, oftentimes we miss the fact that the patient had coronary disease because the vessel was open, but they actually had plaque on the outside of their vessel. In a coronary CT angiogram, we're not going to miss it. And so it tends to overcall the severity of how much blockage is there. And that really makes it a challenge as far as in a lot of our performing it on our older patients who have a lot of calcium there. If someone has a very fast heart rate, then we have to slow it down. If they have an arrhythmia like AFib, or if they're overweight, where the image quality is just not as good because the X-ray has to pass through more tissue. All of those factors can push us one way or the other, whether to do a functional test or to do an anatomic test like CT. So I'll finish up here talking about the mitral valve. And so remember, the mitral valve sits on the left side here. It's got two leaflets to it, one in the front, one in the back. And its job is to swing shut and keep blood from leaking from the left ventricle into the left atrium. So as the heart squeezes, if this valve doesn't close, it pushes blood backwards in the system, which you don't want. Instead, you want blood pumping out the aorta. And so if it's going backwards, it's kind of wish-washing back and forth here. And so here you can see a transesophageal echo on a patient who has mitral regurgitation. And so as the valve closes, you can see this big jet of regurgitation that is going backwards in the system. They have a very enlarged left atrium. And here they have these leaflets are attached to the ventricle through cords, little parachute cords. And when one of those ruptures, then the leaflet can sneak backwards. And so you can see here coming at you is this torn chordae on the posterior leaflet or the back-sided leaflet. And that allows for blood to regurgitate or to go backwards in the system. And so to fix this, you can do a couple different things. One is you can go through the front of the chest and you can cut out the old valve and sew in a new valve. You can either do a mechanical valve like this, like we talked about before, or a tissue valve, either cow or pig tissue. Or you can see if you can do a repair. And so a repair is where we put in a ring that cinches the leaflets together again, and then we put in new cords to tie down that chordal rupture that's been there. There are times where, if there's no coronary disease, we can go through the side of the chest. And so if you go through the ribs here and spread them apart, and then that deflate the right lung and tilt the heart up on its side, you can operate through the back side of the heart. And that exposes the left atrium, and you can go in and replace a valve through the side of the chest now, rather than through the front. And many of those patients get out of the hospital sooner and have a little faster recovery. The other way is if, or other problem that can happen is where someone has already had a bioprosthetic valve put in place where over time it narrows. And so there are times where this valve begins to fail and the leaflets become narrowed. We now have a way of going in through the leg. And so putting a catheter up here to the interatrial septum, poking across into the left atrium, and then putting a wire down through the valve, and then feeding our equipment up and over, just like we did with the TAVR valve. So it is actually a TAVR valve going into an old surgical valve, blowing up the balloon, and then now you have a new valve leaflets taking over or pushing those old valve leaflets out to the outside, and you've replaced the valve from the leg rather than putting them through surgery again. And so here's a patient who you can see on 3D TE, their leaflets are not opening like they should. And so we went in and did that procedure. And here you can see after the procedure, we've put in the new transcatheter valve, and now the leaflets open widely. And so it was a big success. All of the stenosis across the mitral valve was now gone. And here's what it looked like afterwards. As we expanded the stent cage valve in the old valve, you can see the TE probe here, and the wire is still across, and so it's taken over for the old valve. So in summary, those are the ways that that's kind of the things that I get to do day in and day out. It really is, it's a really fun job. It's a way to look at the heart in lots of different ways, using imaging to peer inside the body and diagnose and treat cardiovascular disease. It's very, very gratifying when we get a good result like that and get to help patients live longer and feel better.
Thanks, Nathan. I'm going to try to summarize a number of questions here. You've talked about these several scenarios. These are not the only scenarios in cardiology. These are just examples. You've shown us some gorgeous pictures of some amazing technology, and these are essentially bright, shiny tools. These are things that are fun to do and fun to use. But perhaps you can talk a little bit about what you and I end up talking about, and what you talk about with your colleagues and other primary care docs when it comes to patient care, and that is, how do you decide which things to do when thinking about a clinical scenario or clinical situation? We've got lots of questions about, oh, I've got these risk factors and what tests should I do? Or I have a family history but no symptoms, but it's concerning and should I check something? So maybe we can step back a bit with view towards these tools and view towards these scenarios and talk a little bit about the diagnostic approach to cardiology. How does that work? How do you think about that?
So it's a great question. And this whole process of medicine is just fascinating, right? You get this patient in front of you that is trying to communicate something that's going on inside of them and trying to relay that to you, and you're trying to use all of your skills and training to match that up with some kind of pattern recognition that, yes, I've seen that, I've heard that, this sounds like it could be this, or no, it sounds like it is not that. I'll give you an example. So a patient came to me today or yesterday, I think it was today, and said that they were having sharp stabbing chest pain. And so, that is a great symptom because we know from our experience, and people through the ages have done lots and lots of studies on patients that come in with chest pain and various different descriptions of it. And so we know that in patients who come in with sharp stabbing chest pain, the likelihood that that person goes on and has some kind of cardiac event or has a study that's done that that shows that they have blockages in the coronaries is very, very low, especially if you can localize it at one point with a finger. And so that's really helpful to know. Same is true with patients that come in and say, it hurts when I take a deep breath. If they come in and say, I'm having chest pain, but it hurts when I take a breath in, I say, great. That is a very specific sign and symptom that this is not from your heart. That is a very typical findings that we would see in someone who's got inflammation around the lining of the lungs or of the heart. And so in all of these various scenarios, it really takes a good doctor to listen to the patient and take the time to ask the right questions, the who, the what, the where, the when, the why, and ferret out what is actually going on. And asking the right questions will lead you often quickly to the right diagnostic and treatment pattern. So if someone comes in and says, I'm having sharp stabbing chest pain, that patient does not need a stress test or really any other workup. Most of those scenarios are in the chest wall. There's either the bones, muscles, ribs, linings of the heart and lungs. The same is true with someone that hurts when they take a deep breath in. That patient may have pericarditis or pleurisy, and that's a very different treatment pathway. That person does not need a stress test looking for blockages in their coronaries. When we talk about someone who comes in and says, hey, my sister, my brother, or my dad, or someone just died of sudden cardiac death or a heart attack or something like that. And they say, I'm really concerned, I'm worried that I am going to be in that same boat. That takes but they're having no symptoms whatsoever. That takes someone with, a keen eye towards what are their personal risk factors. And so that's a great discussion to have where we go over someone's blood pressure and their cholesterol levels and whether they have diabetes, whether they're smoking, and their weight and their diet and their exercise regimen. And we think about how can we lower the chance of whether you are at risk for having a heart attack. In general, a patient without symptoms is not a good candidate to have a stress test. Stress tests are diagnostic tests to try and determine whether someone's symptoms of chest pain are related to blockage in a coronary artery. Whereas a screening test is like a calcium score. A calcium score is screening for risk. And so that is done without symptoms to determine whether we should be more aggressive in lowering someone's risk factors to prevent a heart attack from happening in the future.
Thanks. Since you're talking about screening, this has come up as a question in some of our other talks. Apparently, people in this area are receiving flyers and mailings about a company doing cardiac screenings, generally with ultrasound, but other sorts of things outside of the medical system. It's a direct to consumer. Hey, let's do a test and see if you've got risk factors for heart disease or risk factors for stroke or other sorts of things. I'm wondering if you're familiar with that and if you have any thoughts or comments about that kind of an approach.
Yeah, certainly. So we have many patients who come in with lifeline screenings. And so lifeline screening is, oftentimes they'll have booths at a fair or at some other kind of community event where they do a number of kind of cursory tests like an EKG and do some blood pressure on the arms and legs and maybe a lipid panel, blood pressure, and kind of look at your carotids and see if there's any blockages there. All of those, so the Lifeline screening tests, it's not to say that it's wrong. And I think if someone wanted to, pay out of pocket for something like that, many of those screening tests, if you kind of applied those in large populations, have not been shown to be cost effective, meaning that the number of people that you have to screen to find a case to prevent either a stroke or a heart attack, in general is not cost effective to apply on a large population basis. And so really it is, marketing from companies that want to provide this service. But in general, I have a fair amount of skepticism of whether someone should pay for that kind of service. If it were me or my family member, typically I tell them it's not worth it. So.
I'm looking to see if there's any last questions here. I know Dr. Funk is on call and one of his colleagues is stepping in for him while he's doing this talk, so we need to be respectful of his time and let him go. I think what we're hearing, Nathan, is that there are lots of tools and lots of things available that they don't replace a good history, a good discussion, a good physical exam, and then the tests need to be used with careful discretion.
It's an excellent summary.
All right. Thank you. Thanks for spending the time with us. We have one more talk in this series. Next Wednesday at the same time, Dr. Dodderman will be speaking. And I don't have the title of his talk here.
How to make your heart run to 100.
Ah, very attractive title.
Yeah.
All right.
Thank
Well,
you.
thank you everyone for joining us. And hopefully we will see you next week. Thank you to Dr. Funk.
Thank you all. Have a great night.